Hello, everyone, and welcome to our module on paroxysmal supraventricular tachycardia. So let's start by talking about what we mean when we say paroxysmal supraventricular tachycardia, or PSVTs. So PSVTs are arrhythmias that result in intermittent tachycardia, and so by tachycardia, I mean a heart rate over 100 beats per minute. And they have a sudden onset and offset. That's why the word paroxysmal is in the name. A paroxysm is something with an abrupt onset, and so these tachycardias have a very abrupt onset. And this is in contrast to other tachycardias like sinus tachycardia. So if you go to the gym and start exercising, your heart rate gradually picks up over time from a normal heart rate to a fast heart rate. PSVTs are totally different. A person with a PSVT can have a normal heart rate, and then a second later, they can be beating at 150 beats a minute. That's the sudden onset nature of PSVTs. And then the word supraventricular is in the name of the disorder because the electrical activity originates above the ventricle. It is supraventricular. And this is in contrast with ventricular tachycardias. So in ventricular tachycardias, which are very different disorders, the electrical activity originates somewhere in the ventricular muscle fibers, and this creates a wide, bizarre-looking QRS complex. In contrast, PSVTs initiate usually at the level of the AV node or above, so the electrical activity travels through the normal electrical system, and therefore the QRS complex is going to look normal. It's going to be narrow with a normal duration of less than 120 milliseconds. So here's a picture of a PSVT on the slide here. So first of all, notice that the QRS complexes are very close together. They're separated by about two big boxes on the EKG, so that means the heart rate in this example is about 150 beats per minute. And then notice that these look like normal QRS complexes. They're narrow, they're less than 120 milliseconds. They're not wide and bizarre like the QRS complexes you get in a ventricular tachycardia. So this example on the screen could be a patient with a PSVT. And the way the patients usually come to clinical attention is the PSVT is often associated with the sudden onset of palpitations. So many patients with PSVT will tell their doctor, sitting at home, I felt fine, and then suddenly my heart was racing. That's the history of someone who has a PSVT. Rarely you can get other symptoms like chest discomfort or very rarely syncope, but usually palpitations are the main complaint of patients with this problem. So PSVTs are a general term for a number of different arrhythmias, and there are basically three groups of arrhythmias that lead to PSVTs. The first one is AV-NRT, and we're going to talk about that in the rest of this video. The second group are Wolff-Parkinson-White related tachycardias. I talk about Wolff-Parkinson-White in another video, but it involves an accessory pathway or a bypass tract, and that bypass tract can lead to tachycardias, and those are the second group of tachycardias that cause PSVTs. And then the final group are the atrial tachycardias. I won't really talk about these much in this video or any of the others, but these are tachycardias where some of the atrial myocytes are depolarizing spontaneously and causing a tachycardia. Okay, so now let's talk about AV-NRT, which stands for atrioventricular nodal reentrant tachycardia. It has the term atrioventricular nodal in it because the arrhythmia originates near the AV node, and then it's a tachycardia. That's why it's called tachycardia. And I'll explain in a minute why it's called reentrant. That has to do with the mechanism by which the tachycardia develops. But you should be aware that AV-NRT is the most common cause of PSVT. It's more common in young women. The mean age of onset is about 32 years of age. And the pathophysiology requires dual AV nodal pathways. You must have this for this arrhythmia to occur. Let's talk about what that means right now. So remember that normally the SA node is the dominant pacemaker of the heart. It sends out electrical signals to depolarize the atrial myocytes. Then those signals spread through the AV node and down into the His bundle and the bundle branches and the Purkinje fibers, and that eventually depolarizes the ventricle. In most of us, all the cells in the AV node are similar, meaning they all conduct electrical impulses at the same speed. But for unclear reasons, some of us are born with dual pathways in our AV node, and that's what can lead to AV-NRT. So when a person with a dual pathway in their AV node, they have some cells near their AV node or in their AV node that conduct slowly, and they have other cells that conduct quickly. So we say that they have two pathways, a slow conducting pathway and a fast conducting pathway. In these patients, the slow pathway has a short refractory period. This means that even though the impulses travel slowly down this region around the AV node, the cells can quickly depolarize again after they have depolarized once. In contrast, the fast pathway has a long refractory period. So those cells, once they've conducted an impulse, they have a long refractory period before they can conduct again. Now, when the patient is in normal sinus rhythm, there are usually no consequences to the dual pathways. What will happen is electrical activity will come down from the sinus node and the atria. It will spread quickly through the fast pathway and then up the slow pathway, and it will meet signals that are coming down the slow pathway, and they will cancel each other out. And then other depolarizations from the fast pathway will go down to the His bundle to cause depolarization. So a person walking around with dual pathways in normal sinus rhythm will never know that they have dual pathways and that they're at risk of AV-NRT. But now let's talk about what happens when a PAC comes in. So a PAC is a premature atrial contraction, and all of us can have these from time to time. They're common in normal hearts. Well, if a PAC comes in at just the right time, it will send an impulse down into these dual pathways, and the fast pathway, which has a long refractory period, won't be able to conduct signals. It will be refractory, and the electrical activity cannot go down the fast pathway. But the slow pathway with the short refractory period is ready to go. So signals will go down the slow pathway and then down to the His bundle. Signals will also come up the fast pathway, and many times they are able to go all the way up the fast pathway and then re-depolarize the slow pathway. And the result is that you get a circuit through these dual pathways going down the slow, up the fast, down the slow, up the fast. And it all requires a PAC to kick it off. So the key points here are that in order to develop the AV-NRT arrhythmia, patients must have dual pathways, a fast and a slow in their AV node, and they need a PAC to initiate the arrhythmia. And then I've cleared away my ink so I can show you one final point, which is that since the re-entrant circuit here is going around in a circle like this, it is not only sending signals down to the His bundle, which will depolarize the ventricles and create QRS complexes, it also sends signals upwards to the atria, and that can create what are known as retrograde P waves. They look like normal P waves, but they're created by retrograde or backwards electrical activity going from the AV node upward into the atria. And so if you look closely at the EKG from a patient with AV-NRT, you can actually see the retrograde P waves. This is one right here. Notice it comes right after the QRS complex. Here's another one here. Here's another one here. You can also see them down along the bottom. So these are another hallmark of AV-NRT. Besides the dual pathways and the initiation by PAC, they also generate retrograde P waves on the EKG. And so bottom line is AV-NRT is relatively uncommon, and it can be hard to understand this as a first or second year med student. But on this slide, I've written down the key points that I think you should know about this arrhythmia. So first of all, you should know it requires dual pathways, fast and slow, in or around the AV node. It requires a PAC to initiate the tachycardia. It creates a narrow complex tachycardia like what we see on the screen here, and you can also find retrograde P waves on the EKG. So as I mentioned before, the main clinical issue with AV-NRT is that it often causes palpitations which can be uncomfortable. Many of these episodes of tachycardia and the associated palpitations will spontaneously resolve, but when you see patients, they will tell you that they have had on-again, off-again palpitations over a period of time from their AV-NRT. We're going to talk about treatment now, but first let me mention that if the patient has hypotension or shock from AV-NRT, they should have an emergent electrical cardioversion. It's very rare for AV-NRT to cause this. It usually only happens if people already have a sick heart for some other reason. But especially for board exams, you should know if they show you paroxysmal supraventricular tachycardia that you think is AV-NRT and the patient is unstable, then they need an emergent cardioversion, which will usually terminate the arrhythmia. But for most other patients who don't have hypotension and shock, what you want to do to stop this arrhythmia if it's ongoing and won't break on its own is to do something that slows conduction in the AV node. This will break the arrhythmia. What this does is it slows conduction to the point where conduction is not possible through the slow pathway. So remember, we've got a slow and a fast pathway. So if you do something, either a maneuver with the patient or you give a drug that makes conduction in the slow pathway even slower, eventually it will just shut down and there'll be no conduction here. And then the patient goes back to being a patient with a single pathway and the AV-NRT will terminate. And so the things we do to slow conduction in the AV node generally fall into a couple of categories. The first is carotid massage, which I'll talk about next. Then there are vagal maneuvers, and then there are drugs like adenosine. So carotid massage is a maneuver that you may get to see performed on a patient in the emergency room if someone comes in with a PSVT. The way you do this maneuver is the examiner presses on the neck near the carotid sinus, and this is going to stretch baroreceptors which are found in the carotid sinus. This is going to trick the brain into thinking there's high blood pressure because normally high blood pressure stretches these baroreceptors. And the brain's going to respond by increasing the vagal tone to the heart. And one of the things that's going to do is slow conduction through the AV node in general, but often it will shut down conduction through the slow pathway so that the patient no longer has dual pathways. And if you're lucky, you'll get to see this done in the emergency room. It's actually one of the coolest things I get to do as a cardiologist because patients will have palpitations and be very uncomfortable from their tachycardia, and then you have them lie down on the stretcher, you press on their neck, and magically on the screen you see the tachycardia go away, and that's carotid sinus massage. Another way you can break or stop AVNRT is through vagal maneuvers. So vagal maneuvers are maneuvers the patient does that increase vagal outflow to the heart and slow conduction in the AV node. So the classic one is the Valsalva maneuver. You ask the patient to bear down as if they're moving their bowels. There's increased thoracic pressure. This increases pressure in the aorta, and that is sensed by those baroreceptors and leads to a fall in heart rate and AV conduction. You can also ask patients to hold their breath, to cough, to try deep respirations, try gagging or swallowing. There are dozens and dozens of maneuvers that have been described as working as vagal maneuvers. And if you ever get to meet someone who has AVNRT, you'll be surprised how they figure these things out on their own. They'll often tell you, when I get the palpitations, I hold my breath and they go away. They've basically figured out on their own how to do a vagal maneuver for themselves. And then finally, there's a drug called adenosine, which is sometimes used in the emergency room when patients have supraventricular tachycardias like AVNRT. I talk about adenosine in more detail in the videos on antiarrhythmic drugs, but it has a very short half-life. You can give it intravenously for acute therapy of SVTs like AVNRT, and it will slow conduction in the AV node and usually terminate conduction through the slow pathway. And then I'll finish with just one slide on chronic treatment. So many patients have very infrequent episodes of AVNRT, so they don't need any long-term therapy. But if patients keep having lots of episodes, sometimes they're asked to take an oral drug every day, like a beta blocker or verapamil or diltiazem. These drugs slow conduction in the slow pathway, and the idea is that they will slow it enough that the patients won't have episodes of AVNRT. And then finally, for patients who are having lots of episodes that are breaking through on drug therapy, there is a surgical ablation procedure that can be done. Basically, an electrophysiologist identifies the slow pathway and then burns it, meaning turns it into scar tissue so it no longer conducts. And then the patient no longer has dual pathways for the development of AVNRT. And that concludes our module on PSVTs.